let's continue talking about the neurohypothesis. And we're going to talk about the antidiuretic hormone. So the neurohypothesis serves as a storage and release site for the antidiuretic hormone and oxytocin. Okay. But I also want you to know that it's actually the hypothalamus. Remember that little guy, the hypothalamus that does so much? Well, it also synthesizes the antidiuretic hormone and oxytocin. I want you to know that. So you want to highlight that in your notes really big. The hypothalamus synthesizes the antidiuretic hormone and oxytocin. So, what is a diuretic? If I give you all a diuretic, what do I want you to do? Eat. Yes, I want you, so if I give you a diuretic, what are you probably suffering from? Yes, edema, right? Edema. So you have lots of fluid that you're retaining. So I'll give you a diuretic so you can urinate more to get rid of that excess fluid. So you want to know the antidiuretic prevents the formation of a large volume of urine, thereby helping the body to conserve water. Causes a portion of each tubule in the kidney to reabsorb water from the urine it is forming. So an antidiuretic hormone is just the opposite of a diuretic. So what's going to happen if I give you, or I'm sorry, if your body is dehydrated, guess what's going to kick in? ADH, that antidiuretic hormone, so that it can help you conserve the fluid. So if you have a patient that has had chronic diarrhea for the last 3 days and they're vomiting, well, guess what's kicking in? That antidiuretic hormone to try to prevent them from becoming dehydrated. I want you to know that. I've already told you the antidiuretic hormone and oxytocin are synthesized in the hypothalamus, and dehydration triggers the release of the antidiuretic hormone. So you want to commit that to your memory. Before I start talking about oxytocin, do you remember what the function of prolactin is?
Yes, it is to stimulate the memory.
Yes, it's good. Yeah, it stimulates the memory of nerves to produce milk. Oxytocin, and again, it's produced by the hypothalamus, causes milk ejection. Okay, so oxytocin is the ejection of the milk. And it's regulated by a positive feedback mechanism. I also want you to know that oxytocin stimulates the contraction of the uterine muscles that occurs during and after childbirth, which is regulated by a positive feedback loop. Because what's a positive feedback loop? What's the characteristics of a positive feedback loop? Yeah, it reinforces the change. It amplifies the change. It wants it to occur, right? Okay, so far? Okay. Let's talk about the pineal gland. tiny pine nut shaped structure. And it's really kind of cool because it's a member of the nervous system because it receives visual stimuli. What's the visual stimuli? Well, it starts secreting or working at night, right? So when there's no sun, the pineal gland will release the hormone melatonin, and that will help us sleep. So it's a member of the nervous system, but it's also a member of the endocrine system because it secretes hormones like melatonin. Okay, so it's really kind of cool there. The pineal gland supports the body's biological clock, and of course, the principal pineal secretion is melatonin. Is it okay to take supplemental melatonin? Is that what you see? Yeah. Yeah, the problem is, if you take a lot of it every single night, what's the pineal gland going to stop doing? Yeah, it's gonna stop secreting it, so your body is going to rely on the supplement, rather than it occurring naturally. Okay, let's talk about the thyroid gland. The thyroid gland. On slide 19, the only thing I want you to know is the weight. It's 30 grams or 1 ounce. And the reason I want you to know that is because it's not very big. But when it's not working properly, it wreaks havoc, right? Causes lots of problems. Here is the thyroid gland. This guy right here. Like I said, not very big, considering all the problems it causes if it's not working properly. I want you to know that you already know, what are the two hormones that we already know that the thyroid gland secretes? We've already talked about it. TSH, which is the thyroid stimulating hormone. And what's the other one? Starts with a C. Calcitonin. Calcitonin. Now I'm going to introduce you to two more hormones, and that's T4 and T3. T4 and T3. So the thyroid gland stores a considerable amount of a preliminary form of its hormones before secreting them. So on slide 22, this is what I want you to know about T3 and T4. T4, the reason we call it T4 is because it contains 4 iodine atoms. 4 iodine atoms, I want you to know that. T4 is 20 times more abundant than T3. Okay, so if I ask you on a test, what do we have more of? You're going to tell me T4, right? A lot more. However, T3 is considered the principal hormone. Even though we don't have as much of it, T3 is the principal hormone. And we call it T3 because it contains 3 iodine atoms. So if you have a patient that we suspect has a thyroid condition, we're going to order a thyroid panel. And it's going to check the thyroid stimulating hormone, and it's going to check T3 and T4. And then we'll determine from the results if there's a problem, if it's high or low, and talk about medications and things like that. You just want to remember, you'll learn this in pharm, there are certain drugs that are lifelong, which means when a patient has to be put on thyroid medication, it's not a cure, it's not a fix, really. They have to be on that medication for the rest of their lives. Okay, and we have several drugs like that, but once we put our patients on them, they have to stay on. Thyroid hormone helps to regulate the metabolic rate of all cells, cell growth, and it is said to have a general target. But I want you to think about the first sentence there. Thyroid hormone helps to regulate the metabolic rate of all cells, every single cell in our body. That tells you right there how important the thyroid hormone is. And do you remember the sheet I gave you comparing hypothyroidism to hyperthyroidism? Just reading those signs and symptoms, you can see how, devastating it is for the patients until we can until we get them treatment. You already know this one. Calcitonin is produced by the thyroid gland. It may subtly influence the processing of calcium by bone cells by reducing calcium levels and promoting conservation of the hard bone matrix. So remember, if our calcium levels are high in the blood, what's going to be released? Calcitonin. And let's talk about the parathyroid gland. We have 4 or 5 parathyroid glands. The parathyroid hormone is an antagonist to calcitonin and the primary hormone that maintains calcium homeostasis. So if I ask you in the exam, what 2 hormones are responsible for calcium homeostasis? You're going to tell me.
Parathyroid hormone.
Yeah, the parathyroid hormone and calcitonin. Which one is most important in calcium regulation? The parathyroid hormone. Okay. The parathyroid hormone. It's the primary hormone that maintains calcium homeostasis. The parathyroid hormone causes more bone to be dissolved. The parathyroid hormone also causes phosphate to be secreted by the kidney cells into the urine to be excreted. So, if I asked you on an exam, when does the parathyroid gland release more of the parathyroid hormone regarding calcium regulation? You got it, when calcium levels are low in the blood. So remember that core folder I keep talking about that I want you to start making, right? If I were you, I would print this slide out. It's an excellent visual of a negative feedback loop comparing what happens when calcium levels are high in the blood and what happens when calcium levels are low in the blood. So let's look over here at high blood calcium levels first. And this is not a pathology. This is normal physiology. It's happening right now as you're sitting there. Right? As you're sitting there right now, let's say your calcium levels are a little too high. What's going to detect that? Your thyroid gland. Your thyroid gland is going to say, hey, calcium levels are too high. So it's going to increase the release of calcitonin. And by doing that, the release of that calcitonin is going to cause a decrease in the breakdown of the bone matrix. And by doing that, you're gonna have a decrease in calcium levels in the blood, and it's gonna go back to normal, because you don't have a pathology. This is normal physiology. It's happening all the time. Now we come over here, now it's changed. Now your calcium levels are a little low in the blood. What's going to detect it? The parathyroid glands. What are they going to release? The parathyroid hormone. The parathyroid hormone is going to cause an increase in the breakdown of the bone matrix, so that we can have more calcium levels that are, or more calcium that will go into the blood. Okay, normal physiology. Okay with this? What if our patient suffers from osteoporosis? Which one will they be suffering from? High blood calcium levels or low blood calcium levels?
High blood calcium.
High. Because what's happening to our bones in osteoporosis? Oh,
They're breaking down.
they're breaking down, right? And if they're breaking down, that means the calcium is going, more calcium is going to be released into the blood, where it should be staying in the bone, right? We only want a certain amount of calcium in our blood at all times, right? And that's where this negative feedback loop comes in. And when we do that fluid and electrolyte workshop, we're going to see what happens to our patients when they have too much calcium in the blood. We don't, I mean, I think when you think of calcium, what do you think of? Yeah, you think of milk, right? You think, okay, I'm gonna have my dairy so I can, you know, keep those calcium levels up. But let me tell you, when our patients are suffering from hypocalcemia, or hyper or hypocalcemia, they could die from it. It is not a joke. And we'll talk about the signs and symptoms. So, and when that happens, it's because we got a pathology. We got something going on. So I really want you to know this. Okay, any questions? Any questions so far? All right. Adrenal glands. Thank you. You already saw a visual of the adrenal glands. Where do they sit? On top of the kidneys. They fit like little caps. I want you to know they're made of two portions, the adrenal cortex and the adrenal medulla. Adrenal cortex is going to be on the outer part of the adrenal glands, and the adrenal medulla will be in the inner part, or center, middle. So here's your kidney. This is from a picture from a cadaver. There's your kidney, and there's your adrenal gland sitting right on top. What did we determine last time that the adrenal gland secreted? So the adrenaline. Excellent. Okay. So if we were to look at the cortex under a microscope, this is what it would look like. And I want you to know there's three zones that I want you to know. There's the zona glomerulosa, which is going to be here. It's right at the top. There's the zona fasciculata, which is going to be the middle zone. And the zona reticularis, which is going to be, it's referred to as the inner zone, or the deepest zone. And then right under that, we have our medulla, which is the middle. So I want you to be able to recognize all three zones of the adrenal cortex. And I want you to be able to recognize what each one secretes. So for instance, the zona glomerulosa of the cortex secretes aldosterone. Aldosterone. Have you ever heard of that before? That hormone, aldosterone? Okay, so we're gonna talk about it in a minute, but why don't you put this in your notes now? Aldosterone helps us retain fluid. It helps us retain fluid. So it's kind of similar to the antidiuretic hormone, except it will help us also, or I shouldn't say help us, but one of the functions is that it will enable us to retain sodium and get rid of potassium. Retain sodium and get rid of potassium. We'll talk about that all in a minute. But that's aldosterone. You want to know that the zona fasciculata secretes an abundant amount of glucocorticoids, chiefly cortisol. Now, we have lots of glucocorticoids. The only one you're going to be responsible for is cortisol. Why? Because under stressful situations, our body tends to release lots of cortisol, which causes what?
Stress.
Yeah, well, the stress causes the release of a lot of cortisol, which in turn causes abdominal fat. Okay. So, I want you to know that cortisol. The zona reticularis secretes minute amounts of sex hormones and glucocorticoids. So all adrenal cortical hormones are steroids and are known as corticosteroids. The adrenal cortex is composed of 3 distinct layers of secreting cells. We already talked about them: zona glomerulosa, zona fasciculata, and zona reticularis. And this is just repeating what I said that each one releases. So you want to know your zones. This is a nice little visual, actually. So you've got your zona glomerulosa, the zona fasciculata, and the zona reticularis. Any questions so far? Okay? Okay. So let's talk about mineralocorticoids and glucocorticoids. They play an important role in the processing of electrolytes in the body. What are electrolytes? Yeah, calcium, potassium, sodium, magnesium. Aldosterone, only physiologically important mineralocorticoid in the body, and that's the only one you're responsible for, which is good for you, right? Yeah, it's the only one you're responsible for, aldosterone. I already told you that it increases water retention, and it promotes the loss of potassium and hydrogen ions. And glucocorticoids, remember the main glucocorticoid secreted by the zona fasciculata is cortisol, and that's the only one you have to know because it's the only one that's secreted in significant quantities. So the primary function of aldosterone is the maintenance of sodium homeostasis in the blood by increasing sodium reabsorption in the kidneys. So you want to think of aldosterone as keeping that salt, okay? It's keeping the salt. I want you to know that the aldosterone secretion is controlled by something that we call the RAS system. The RAS system. So it's renin, angiotensin, and aldosterone system. So if you know what those letters mean, you already know the three players in the RAS system already, right? You know renin is part of the RAS system. You know angiotensin is part of the RAS system, and aldosterone. It gives you the three of the players in the name. So glucocorticoids affect every cell in the body. Glucocorticoids are essential for maintaining normal blood pressure by aiding norepinephrine and epinephrine in reaching their full effect, thereby causing vasoconstriction. So what does vasoconstriction do? Is it going to increase your blood pressure, or is it going to decrease your blood pressure? It's going to increase it. And I know this sounds a little confusing, right? But here's what I want you to think of. I want you to think of a garden hose, okay? Let's pretend I have a hose, and I turn the water on, right? And then I bend the hose. And then I turn the volume way up. So what happens to the pressure? It goes up, right? And what else happens? What happens to the volume? It builds up, right? Because I am stopping that water from going through. So you gotta build up a pressure, you gotta build up a volume. So if we have that with our blood vessels, what's it going to cause our patient to have?
Hypertension.
You got hypertension, high blood pressure. Does that make sense? So I always want you to associate vasoconstriction. It's going to increase the blood pressure. It's going to make it go up. Vasoconstriction. All right. So this is the RAS system. This is it's an excellent visual of the RAS system. Now we haven't talked about the kidneys yet, but I'm going to give you like a little preview here. Here's our kidney. It's actually cut in half. So you got the cortex of the kidney here. You've got in the middle is the medulla, or the medullary part of the kidney. And here, look what's sitting on top, the adrenal cortex. Okay. So I want you to know that in the RAS system, and first of all, let me just say this first. The RAS system is activated when our blood pressure is low. Okay. This is normal physiology. So you're sitting here right now, and your kidneys detect, this is kind of weird that kidneys would do this, but the kidneys detect that your blood pressure has dropped a little bit. Okay? Well, we don't want that to happen, right? So the kidneys are going to come in and they're going to secrete a hormone called renin. When that hormone is secreted into the bloodstream, this angiotensinogen, which is found in the liver, is going to be converted to angiotensin 1. Now, we're halfway there. We've got angiotensin 1, but we need to get to angiotensin 2 in order for our blood pressure to go up, right? So how's that going to happen? Well, the angiotensin 1 is going to bind with the angiotensin converting enzyme ACE. When it binds to ACE, now we're going to have angiotensin 2, which is going to cause our blood pressure to come up, or to go up. The aldosterone is going to kick in, and what's the aldosterone do? It's going to conserve water, right? So it'll help us retain fluid. What's going to happen to the sodium? It too is going to increase, and it's going to get rid of the potassium. The other player in this that it doesn't show is the antidiuretic hormone. It too plays a part in this because it's going to help aldosterone retain the fluid. This is normal physiology. So when is the RAS system activated? When our blood pressure is low. And after the renin is released, angiotensinogen, which is in the liver, is going to be converted to angiotensin 1. Angiotensin 1 is going to bind with this angiotensin converting enzyme called ACE, and it will now become angiotensin 2, and it's going to cause our blood pressure to go up. And that's what we want,
So
right?
what are ACE inhibitors?
Yes, I was waiting for someone to ask that. ACE inhibitors. So if this ACE, this angiotensin converting enzyme, helps raise your blood pressure when it gets too low, well now, what if the patient has a pathology? What if they have hypertension? What can we give them? We give them an ACE inhibitor, and that ACE inhibitor will prevent this from happening. So their blood pressure won't go up all the time. Remember, this is normal. This is normal physiology until it's not, until we have a pathology. And then we have to prevent this from happening. Okay, so whatever, and what's a perfect example of an ACE inhibitor? I think we talked about it. Lisinopril. Lisinopril. And lisinopril is a great drug because it also protects the kidneys. But a lot of people can't take it because they develop that chronic cough. Yeah, so we have to be careful with that.
And then
They won't
you
get
have
used to
COVID.
it, so, I'm sorry?
And then they get COVID.
Yeah, you have it. It's, again, for you as nurses, a lot of times doctors don't tell their patients anything. I do though, but a lot of doctors do. So as nurses, you're going to have to say, say your patient was put on propranolol 3 months prior, and you're going over their chart, ask them, just say, you know, how are you doing? Do you have a cough? Or, you know, you really want to make sure that they understand that it could be the lisinopril that's causing the cough. And if it is, they have to be taken off of it because it won't get better. The body doesn't get used to it. So angiotensin converting enzyme ACE is produced by capillaries throughout the body, but is mostly concentrated in the lung capillaries. So okay with that? That's what I want you to know about the RAS system. Your pharmacology instructor will more than likely review that next semester. But if you know what I told you, you should be in really good shape. Okay? The RAS system. Adrenal medulla. The adrenal medulla secretes 2 important hormones, epinephrine and norepinephrine. I want you to know that, please, which are part of the class of non-steroid hormones called catecholamines. So if I were to ask you on a test, what are 2 examples of catecholamines? What are you going to tell me?
Epinephrine and norepinephrine.
You got it. Epinephrine and norepinephrine. Okay, let's talk about the pancreas. The pancreas. pancreas has, and I just wanna point this out so you have a nice visual. This is the pancreatic duct that is used for digestive juices. So, when we talk about the digestive system, we think of the colon and the small intestine, but the pancreas actually plays a big role in digestion. And if our patient is suffering from any type of pancreatic issue, whether it's pancreatitis or pancreatic cancer, whatever it may be, what's going to bring them to the hospital is lots of abdominal pain. I mean, they are going to be in severe pain. So you want to know that the pancreas weighs about 100 grams, 3.5 ounces. And you're going to be able to see this on the cat. But the head lies in the duodenum, and it extends horizontally behind the stomach and then touches the spleen. So the tail of the pancreas actually touches the spleen, while the head lies in the duodenum. So it covers a large area. That's why it's so deadly when something goes wrong. Okay. With pancreatic cancer, it spreads to the spleen, of course, because the tail, touches the spleen, and then it will spread to the liver. And unfortunately, that's usually when people are diagnosed, is when it's already spread to the liver, and that's stage 4. And there's not, we haven't been able to successfully treat stage 4 pancreatic cancer. Now, if we can catch the pancreatic cancer before then, the patient has a shot. We can, you can live without a pancreas. So they can remove the pancreas, they could do a lipo procedure, and the patient could, survive and live a long time. But it would throw them into type 1 diabetes. So they would be diabetic, type 1 diabetic for the rest of their lives. So they would be insulin dependent. So there's a few cells that I want you to be aware of regarding the pancreatic islets. I want you to know the alpha and beta cells. So alpha cells secrete glucagon, and beta cells secrete insulin. I want you to know that. So if your patient's diabetic, there's a problem with those beta cells. If they're type 1, the beta cells are not secreting insulin at all. Type 2, the beta cells are secreting insulin, but usually not at great times. And I want you to know that epsilon cells secrete ghrelin. And ghrelin actually is thought to regulate our appetite. So if you have someone that has, an enormous appetite, we may be able to blame it on these epsilon cells, okay, because they're not working properly. So pancreatic hormones, glucagon tends to increase blood glucose levels and to stimulate gluconeogenesis in liver cells. So once that happens, once glucagon is released and it stimulates the gluconeogenesis in the liver, then glucose is secreted. Insulin lowers the blood concentration of glucose. And pancreatic polypeptides influence the digestion and distribution of food molecules. Pancreatic hormones work as a team to maintain homeostasis of food molecules. this is why, let's say a patient has pancreatitis and, let's say they had it 3 years ago, 4 years ago. What do they still have to focus on regarding their diet? Yeah, they shouldn't eat anything that's real greasy or fat, no alcohol, because it's very, very serious. Usually once someone has pancreatitis, there's the high percentage that it can come back. And we know that chronic pancreatitis can lead to pancreatic cancer. Glucagon is produced again by alpha cells, insulin is produced by beta cells. The ghrelin stimulates the hypothalamus to boost the appetite. It slows metabolism and fat burning, and it may contribute to obesity. So that's something we're looking at. Here's another slide that I recommend you print out and put it in your core folder. At first, when you look at this, and again, this is a negative feedback loop to regulate glucose levels in the blood. When you first look at this, you probably are thinking, well, yeah, we can do that, okay? But you may not know a certain part, so let's look at this. Let's pretend right now that our glucose levels are low. So what's going to happen is that we're going to have an increased glucagon secretion by the pancreatic islets, right? Because our glucose levels are too low, so we want an increase in glucagon. We're gonna have a decrease in insulin because we don't want the sugars to get any lower, right? They're already low. So, increase in glucagon, decrease in insulin. But, look what happens here. We're gonna have a decrease in glucose uptake by cells. A decrease in glucose uptake by cells. Think about what that says. So here's your tissue cells, which every single cell in our body has to have glucose, right? You have to have glucose for what? Energy, right? Energy. So here's our cells. They all got this glucose going on, right? But because now we don't have enough glucose in our blood, well, these cells are gonna say, okay, I'm gonna stop taking so much glucose so it can go back into the blood. Does that make sense? This is where I thought you may not quite get that part. I mean, it's easy if our glucose levels are low in the blood. You know this. Glucagon's going to increase, insulin's going to decrease. But now our cells, we're going to have a decrease in the glucose uptake by our cells so that more glucose can go back to the blood to maintain homeostasis. It's what's happening right now as you're sitting there, unless you have a pathology, right? So let's look at this one. If we have high blood glucose levels, well, just the opposite's going to happen. Your insulin's going to kick in, and you're going to have a decrease in glucagon. And now you're going to have an increase of the glucose uptake by the cells so that it won't all go into the blood. We won't have an excess amount going into the blood. Does that make sense? Let me know if it doesn't. Okay, you want to really know this about the cells. I know you know those two. These two here, I know you know that. But I want you to understand this. This is why when someone suffers from diabetes, it's so devastating. It's a very insidious disease because our patients usually don't associate eating that chocolate pie with not feeling well the next day, right? But it affects every single cell in their body. That's why they go blind if we can't control it. That's why they have nerve damage. That's why they have kidney issues. Their kidneys, diabetes destroys the kidneys. And they feel terrible. I don't know if you know of any diabetics, but if their diabetes is not controlled, they have zero energy. They don't want to do anything. Right? And as the disease progresses, it just gets worse. So again, insulin and glucagon, two of the major pancreatic hormones, they have antagonistic opposite effects on the glucose concentration in the blood. And of course, many other hormones. We already learned about the growth hormone, how it affects glucose levels. Cortisol, because cortisol makes us gain weight, and it's due to stress. So all of these things influence blood glucose levels. I promised you that I wouldn't test you on these now, and I won't. So don't worry about the reproductive system right now. You don't have to worry about any of this. The placenta, it's a tissue that forms on the lining of the uterus as a connection between the circulatory systems of mom and the developing child. The thymus, what did we learn about the thymus? It's very active when we are children. And when we become adults, it becomes a vestige of fat. Okay. What's it responsible for? T cells and thymosin, which plays a key role in immunity. So you always want to think of the thymus as it's the primary gland for immunity. That's a lot of material, that's a lot. Any questions? When is the RAS system activated?
Your blood pressure is low.
Good, when the blood pressure is low. Excellent.